In this short video, I want to discuss the last two rheumatology cases or rheumatologic screening cases that we did not get to in lab the other day. So for patient case number 3, we're evaluating Mr. T, who's a 40-year-old male who has low back pain that has been progressing from his low back, and now he's complaining of thoracic spine pain and bilateral shoulder pain. So what do we think about his case? Well, he has had back pain ever since he was in his 20s, so onset before the age of 40. And we have kind of a progression from the low back up into the thoracic spine, up into the shoulders. His motion is decreased. Extension and flexion are decreased, and he has pain with those motions. He also has pain and we don't hear stiffness in the morning, but one of the things that we're intuiting is he's stiff and limited in range of motion, and he has pain in the morning. And we also see that he has some postural changes. So he has some increase in thoracic kyphosis, the neck flexion. So he's in this rounded forward position, progressively flexing forward. He's relatively young to be having these changes, and we have multiple areas affected. This isn't necessarily a typical presentation of musculoskeletal pain, and there are definitely some things in here that flag our attention for possible ankylosing spondylitis. So the morning stiffness, the onset was before the age of 40. He's had pain longer than 3 months. It was a gradual onset, no traumatic event. Usually the fifth sign or symptom that we're looking for is improvement with exercise. He actually has exacerbation when he is active. However, 4 out of the 5 screening points that we discussed per cluster of signs and symptoms for ankylosing spondylitis, in addition to the fact that it has been a progressive marching up dysfunction, so to speak, so starting in the low back and progressing up the spine with some pretty severe changes, especially for his age. We may expect back pain to be intermittent, so it may not be uncommon for it to onset at that age and then have intermittent episodes, but for it to be progressive and worsening to this extent without some underlying explanation, we're really suspecting for this individual ankylosing spondylitis. And so our PT decision would be to refer to rheumatologist for case number 3. All right, case number 4, we're evaluating Mrs. S. She's a 55-year-old woman who is suffering from low back pain. Started 4 years ago. It's gotten worse after she had an accident at work. And so now she's having radiating pain down into the buttock and back of the thigh. She has pain when she bends forward. She has pain after an hour sitting, which are both flexion motions. We can intuit a flexion posture in sitting. Has some dermatomal myotomal changes, which are right next to each other, L4, L5. She has some positive neurodynamic testing and pain with coughing and Valsalva, which is consistent with a musculoskeletal pain complaint. So everything about this case history, we don't see anything really that specifically catches our attention outside of a pretty typical normal musculoskeletal pain progression or pain complaint for low back pain. So she had some back pain prior, and then she had a flare-up because of a specific event, an accident at work. She does have radicular pain. We don't have the exact specification whether it's unilateral or bilateral, but we're assuming that this is unilateral without mentioning a bilateral. She has a medium amount of pain, so 5 out of 10, so it's not excruciating. And she does have these things that point to some sort of neurogenic pain generator. So a radiculopathy, so irritation of a nerve root with the dermatomal myotomal changes, radicular symptoms, positive neurodynamic testing, all those things fit what we'd expect this pattern of musculoskeletal pain to look like. So non-specific low back pain, or low back pain with radiculopathy, or low back pain If we do detect a directional preference, we could categorize her based on our treatment-based classification system into low back pain with specific exercises, directional preference. And our decision is to treat. So we are going to treat this individual with low back pain. So those are cases 3 and 4. Hopefully that quick run through helped you all out with a little bit of clinical decision making.